Yeah. Hello everybody, and welcome to our first alumni webinar. My name is Jo Odell.
And I'm Gemma Stacey. I'm here from the University of Nottingham. My background's in mental health nursing, and I'm an associate professor here in the School of Health Sciences.
So we're delighted to welcome you to our alumni event, the focus of which today is gathering staff and patient narratives to improve patient care. Just want to say this is our first event,
yes,
so please bear with us as we get to grips with the technology and get to grips to how to involve you in this discussion. We've just got one more minute to welcome people, so we're just going to hang on one more minute, see if anybody else can join us, and then we'll tell you about how we're going to run it and then go from there.
Yeah, ready to go.
So yeah. It's 1 o'clock, and I'll say again, welcome. So my name is Jo Odell. I work for the Foundation Nursing Studies. I know some of you. I haven't met some of the others who are joining us, but I really wanted to start this idea of an alumni and how we could welcome people into events who've been part of our programs. So this is our first event. We're looking forward to your contribution and also your feedback. Perhaps you can give that to us at the end by email.
Yeah, that'd be great.
Okay, so Gemma, could you just talk us through the ground rules of how this is going to work in terms of the feedback and stuff?
Yeah, absolutely. So we're using this software called Adobe Connect, and it is very clever and all singing and all dancing, but we're just getting to grips with how it's going to work. So for today's session, the way we're going to run it is that Jo and I are going to present some information and some ideas. And we're going to work through some exercises together, and we'd encourage you to make comments in the chat box. So if you can type any comments or questions that you have as we go along in there, and we'll keep an eye on those and try to respond to those as we're going along. And then towards the second half of the session, we've got some questions that we'd like to ask you. And again, if you can respond to us via the chat box, that would be wonderful. For future events, we're hoping to be able to use the audio and also the visual, but for today we're going to stick with the chat box. So in answer to Joanne's question, it's not a one-way thing, but it's not a sound thing, so if you can just respond to us via text. Thanks.
So let's think about how we currently gather evidence to measure both patient and staff experience. Things that I've experienced in my practice, but also in the people I work with, are things like friends and family test. They seem to be used quite exclusively at the moment, especially in acute trusts, maybe not so much in social care. Gathering thank you cards and gifts, as well as informal feedback.
Yeah, absolutely.
As along with complaints. Complaints seem to be registering quite high in how people, measure people's experience. If we think about staff, then the way we can gather staff experience is through staff surveys, through individual performance reviews, and then through exit interviews. But also there might be other ways that you're gathering staff experience.
So from your experience, Jo, what's the effect of gathering this information in this way?
So in my experience, that quite often this is used very much to prove or to assure trust boards or people that are working at senior levels that everything is okay. So it kind of brings me on to thinking about this idea of, are we using evidence to prove or improve?
Yeah.
So a lot of people are gathering evidence, like the friends and family test. They're collating that, they're sending it up to perhaps the patient experience team, the complaints team, and then somebody else is doing something with it. So I'm slightly concerned that people aren't owning that information, they're not have the skills or the confidence to know what to do with that. So just to repeat then, this idea that at the moment we gather a lot of information from both patients and staff, but we use that to prove and to send up to people in our organisations that things are okay and that things are safe. And to a certain degree that's okay, but I have some concerns that people that have the potential influence over patient and staff experience are not being given the confidence skills to know what to do with that. So if you could take me on to the next slide. So quite often the way that we're working at the moment is that we're using two philosophical underpinnings to the way we use data and we use evidence. One is this idea of positivism, which I can't even say, which is this idea that we're using one reality to prove or improve. To prove that something is happening or not happening. So this a typical example of that might be a clinical trial.
Yeah.
So we're using clinical trials to prove that a medicine works or a medicine doesn't work. The difficulty with that, it doesn't tell us where we can improve care. Mm-hmm. So the philosophical underpinning that we're coming from with this idea of using patient staff experience to improve care is something called Constructivism, which I can't even say either, which is this idea that we're using multiple realities to try and understand what people's experience is and how we can then learn from those experiences to improve what we're doing.
Absolutely. My experience has been that in a positivist world where we're trying to control all of the variables and make sure that we're just testing that particular intervention, drug, those kinds of things. And so things like the gender and the age and all of those things and the context are all controlled as much as possible. Whereas from the constructivist perspective, it's all of those external variables that are of most interest to us. Yeah. So it's the kind of real world stuff.
The real world stuff.
Yeah.
So there's also the idea of thinking about satisfaction. What's the difference between satisfaction and experience? So Gemma, if I ask you, if you went to your local supermarket and I sent you a survey on how satisfied you were with their service, what would influence your satisfaction around that supermarket?
I guess things like how easy it was to get the products that I was going to buy and probably the cost of them as well.
Yeah. So I could ask you on a scale of 1 to 5 how satisfied you were.
Yeah.
And maybe you got something half price.
Yeah.
So you'd be very satisfied. But the experience that you had might not match the satisfaction because you might have met a checkout lady who didn't engage with you. You might have had to fight 1,600 people for said product because it was on sale. So when we're talking about taking patient staff narratives or experience, we're talking about something very different to satisfaction. We're talking about understanding their experience and therefore by understanding their experience where we can make improvements.
Absolutely.
Yeah.
So you wrote about this recently.
I did. So recently there's been some research that's come out from the University of Birmingham in collaboration with Warwick and the National Institute for Health Research, and I wrote about it in a blog in October about how we could invest. I was trying to make a case for how we should invest in our staff in terms of confidence and skills to enable them to gather both staff and patient narrative experience and how they can use this and take control of this, rather than just gather it and send it to a big black hole.
Absolutely.
So what this research highlighted in its main findings was that they did a big piece of work looking at mental health trusts specifically and acute mental health trusts. And what they found that is a lot of organisations are gathering patient experience, but they're not actually using it to improve care. Mm-hmm. So what a huge waste of resource.
Absolutely.
And if you think about the economical value of gathering all of this data, but then it's not being used to improve care. So I thought that was very helpful, and it certainly backed up the way I was thinking and the way FoNS is thinking about that. The other thing they said was that even if patients are unwell, they can give really meaningful feedback.
Absolutely.
But we as staff need to be open to that feedback and to both positive and negative feedback. The other key thing they talked about was this idea is that you need a relationship with somebody for somebody to feel safe to give you feedback. And staff need to feel empowered to act on that feedback. So I thought this was a very powerful piece of research. So for those of you who are wanting to undertake some work with your staff and patients around feedback and are struggling with your organisations, valuing that, then this is a great piece of research, and certainly you can look it up on my blog from the 22nd of October.
Absolutely. I think really powerful as well that it's been done in a mental health setting, because again, thinking about how we control all the variables, and we try and often do research that doesn't actually reflect the real world. Often people who use mental health services end up being excluded from that research as a result of that, whereas this is actively sort out those voices.
And I think this is applicable across all organisations, and I think the other people that are very much excluded are older people who have a cognitive impairment. And in my experience, certainly the work we're going to talk about in a minute with the touch points is a way of involving everybody, both staff and patients, well, anybody, any of your stakeholders, in giving you feedback on their experience.
Absolutely.
Okay. So we've just had some feedback from Kelly, who said the sound carries best when facing the camera.
We'll move.
We'll do our best, Kelly. Thank you for the feedback. We appreciate that. Okay, so
you were telling me before, Jo, about how we might approach this, gathering these stories, gathering that experiential data, and you were telling me about these creative approaches that you've come across.
Excellent. But before we go on to that, we've just had some feedback from Siobhan, who talks about people with learning disabilities and how people with learning disabilities, especially young and old people, could. So I would say yes, Siobhan, absolutely anybody can share their experience, but we as professionals have to be flexible about how we enable those people to tell their stories. So that actually takes us really nicely on. So here's some examples of some creative approaches that some of the Inspire Improvement Fellows have taken in terms of trying to get some feedback. So on the left-hand side, you can see Anna's culture tree. I hope you recognise it, Anna. So this is a creative way of asking staff for what's it like to work around here. And Anna created the tree, and then she gave people stickets so that they could contribute to that tree. In the middle, we've got an example from Joanne Mohammed up in Blackburn on how she's used Halloween as a topic to both ask staff and patients what's it like to be cared for in their unit. And on the right hand side, you'll see a Christmas themed bauble one, which is about enabling staff to talk about what's important to us. So I guess my key message here is try and be creative in the way you get your feedback, and be open to hearing that feedback in as many different ways as you can. But try and engage people rather than the patient or the staff. Try and engage people in giving you the feedback.
Absolutely. And I think one of the key aspects of this is that you're asking people to share their feelings. How does it feel to work around here? And again, that's very different to that, are you satisfied or not? It's a kind of very closed question. It really encourages people to think more deeply about it and give us more of that contextual knowledge.
Okay. So some of you who've worked with me quite a lot will know a little bit about the emotional touchpoint idea of gathering experience. But I just wanted to highlight that as a tool, as a method for gathering experience. And then I'll talk through it, and then I'm going to ask Gemma to have a go using the evoke cards.
Yeah,
and we'll try and talk at you rather than talking to each other. So the emotional touchpoint method was developed by Belinda Dewar. She did a lot of work in Scotland around this, and then it was adopted by the co-production movement, and this idea of understanding people's experience through feelings. So a traditional way of gathering touch points is to look at a patient's journey. So I've given you a journey here, an example of somebody coming into an outpatient's department. So some typical touch points on that journey might be, so first of all, receiving the information in the post, second, arriving at the hospital, third, arriving at the reception desk, fourth, waiting in the waiting room, 5, being called in by the nurse or doctor, 6, consultations, 7, leaving the hospital. So I've kind of just given you a broad outline of that. But if you wanted to gather an experience across a patient's journey, that journey would look different for you, and depending on where you are and your client group and who you're caring for. But the idea is that you use the touch points, and then you ask the person that you are gathering their experience to describe that touch point using emotive words or pictures, as you can see there. Okay, so we'll move on. So now what I'm going to ask Gemma to do is to, I've got a list of touch points that, I don't know if you can see that, probably can't, I can send that to you afterwards, of ideas that you might use when you're talking to staff to gather staff experience.
Yeah.
And so Gemma, can you tell us which touch point you decided to use?
Yes, so I was going to talk about a change that I managed when I recently came into the role of Director of Public Engagement here in the School of Health Sciences at Nottingham University.
Great. And what we're going to use is the evoke cards. For those of you who work with me will know evoke cards. I'm using these because they're quite easy to use. They have pictures on one side and words on the other. And so Gemma, would you rather use the words or the pictures?
I've chosen to use the words.
Yeah. Okay. Just to say, other cards are available on the market, and if you haven't got a budget and you'd still like to use this technique, then you can make up your own words or your own pictures and create a set yourself. And I used to do that when I was in the early days of being a facilitator. So Gemma, tell us about your change.
Yeah.
And then share the words with us.
Okay, so the event, I guess, that I was going to talk about a bit about is when I came into the role as Director of Public Engagement, it was a time of quite significant unrest within the school. So we've been working with a group of people that use health services in a whole range of ways to input into our research and our education for a long time. And those people had always been worked on casual worker contracts with us and been paid as any other expert would that's inputting into our curriculum and our research agenda. But there was a change at the time to employment law, and the way that the university responded to that was to say, we can't continue with this way of employing members of the public. Everybody just needs to be volunteers, and the way that we will pay them is just their out-of-pocket expenses. So just as I came into post, this was a change that was being imposed, and it was very much imposed on from a top-down approach, and there wasn't any collaboration or consultation throughout that process, and probably quite limited transparency about the reasons why that decision had been made. So understandably, the members of the public we've been working with felt that really devalued their contribution. They felt really angry with the organisation for the way it had been handled, and also that they weren't gaining the recognition for their contribution that they deserved. So the reason why I'm sharing this particular example is because for me it felt like a real conflict. So I came into the role and just looking at some of the cards that I picked up on was because I was really passionate. So I picked out passionate about the role of members of the public in shaping our agenda, and really how the influence of their narratives and stories could really impact on our work in the school. So I was driven into and motivated by to do the role because of that passion. And I felt very critical, that's another card that I've selected, about the way that it had been handled. So I wanted to use my role and my influence to do something quite courageous and really challenge this decision. But what I found through doing that was that I was in a real kind of conflict position. So in a position where I was advocating for the members of the public whilst also having to uphold this directive from our organisation. I'm feeling quite vulnerable at that stage. There was another card that I identified, and a real sense of a potential that both parties could disapprove of how I was acting and how I was managing that situation. So a very long story is cut short, which ended in us reverting back to a period of consultation understanding actually what the changes to employment law meant to us and approaching it in a much more transparent and collaborative way with those members of the public. And now I'm proud, I've identified to say that we've come to a situation of compromise. We definitely are valuing from an employment status those individuals' contributions again, and they're back engaged with us as a school whilst also complying with these wider directives that we've had to work with in relation to the university's needs as well. So yeah, that's been the kind of the journey in terms of the emotions.
Okay, great, thank you very much. So hang on to any thoughts or ideas you've got now about hearing that narrative, hearing that experience, because I just want to talk through some of the practical issues, and then when we come to the question section, maybe we can have some feedback on what you heard, maybe through listening to emotive words as opposed to hearing exactly what happened.
Mm-hmm.
Is that all right?
Yeah, sounds good.
So some of the practical things to think about when you are gathering a patient staff narrative is really how you're going to record it. Are you going to write notes? Are you going to have sound recording? Are you going to have video recording? Or are you going to take photographs, or both? So we could take a photograph of these words, and we could do something differently, having heard your experience, and then we could repeat this exercise and take another picture of the words and then look at the difference. So that's something that we could do. The other really important thing to think about is your ethical considerations, to think about consent particularly. Now we're working potentially with vulnerable people, so consent is really very important. Whether you think about verbal consent or whether you think about written consent. Your organisations will have guidance on this, but I would always encourage you to work from a very strong ethical framework. The people that you can talk to help you in your organisations, especially those of you working in big organisations, are your patient experience leads, your PALS teams, your complaints teams, all of those sort of people. For those of you working in smaller organisations, you can think about your governance teams, or just generally look at good ethical guidelines on the website. The other thing to think about is anonymisation and making sure that you are very clear about anonymising people as much as you can. And also thinking about, when you're thinking about consent, thinking about not just consenting for this process, but thinking about consenting about what you need to do to, if you want to share this information, which I'm really going to encourage you to do. Nikki's just leaving us because she can't hear, unfortunately, so that's something for us to bear in mind. Sorry about that, Nikki, we'll be in touch. So then the other thing to think about is whether you work with individual people, so you use this approach using individual people, or whether you think about something like a focus group, or you have a combination of methods. Certainly some of the projects that I've sent you links to on your emails have used a combination of methods. Some people have used individual interviews. There's a project up in Newcastle, sorry my brain just went blank there, up in Newcastle, and they were looking at ladies waiting for gynecological surgery, and they realised that these ladies were waiting an awful long time because they were bringing them in at a standard time in the morning, and then they were waiting for surgery something like 1 o'clock. So they utilised that time to understand how they were feeling prior to this quite serious major surgery. So there's also, I didn't actually send you that link, but I can if you're interested. One of the other projects that we looked at was Chris in Portsmouth, who did some work around gathering experience of people from going through a surgical assessment unit, and she used a combination of focus groups and diaries. Diaries are another great way of really understanding people's experience. You can set them up, but people can then document their experience as they're on the move, or if people have a cognitive impairment or they're unconscious, for example, in intensive care, families can use diaries to explain their experiences and their feelings at the same time.
And really powerful to gather that in the moment reflection, isn't it? I guess when we do interviews, we're expecting people to remember events, and they will always give a different interpretation of it, having reflected on it and sometimes past. But the diaries do offer you that opportunity to gather that in the moment experience.
Yeah, absolutely. So you've done all this great work and you've gathered all this experience and narrative, and I guess the thing is, what do you do with it? So the first thing that I really want you to encourage you to do is to really, really listen and hear what that person is trying to tell you. And that is definitely a skill, really understanding and empathizing with that experience and with these very emotive words, which are very, very powerful. The other thing I would encourage you to do is share widely, but in the first person. So it's very easy when you hear a story like this or an experience to transcribe it into your own words, but what you will lose is the power of that emotive. So always tell the story in the first person. So this picture here is of a project that I supported in Wales, and it was a project gathering experiences of miscarriage. And Rachel, who undertook this project, gathered narratives of ladies who had experienced miscarriage, and then she gathered a wide group of stakeholders together, and they all went to the botanical gardens in South Wales, which is a beautiful, beautiful setting, and they hired a professional narrator because the ladies that shared their stories felt too uncomfortable to really be able to tell their stories without breaking down, because very emotive stories. But what was so powerful was hearing those stories in the first person in these beautiful grounds where life seemed to be coming up around us in the spring, and you know, a lot of people left that stakeholder meeting completely changed in terms of how they viewed miscarriage. So once you've shared those widely in the first person, really think about working collectively to identify themes. It's very easy if we think from a approved status that one person gathers all the data and one person gathers all the themes, but each of us will hear different things. And then also it's very important that we work collectively to be part of the solution.
Absolutely. We were talking earlier about the importance of making sure that people remain very much in control of their story. So once we've collected it and we've got that consent to be able to utilise that story, that people know where it is being used, and also are able to be active in thinking about how their story can influence the potential solutions as well. So it's very important, I think, from an ethics perspective, that people remain with that ownership of their story.
Yeah, and enable them to tell it either in the first person, through video or through sound.
Yeah, absolutely.
Okay, so apologies that we're having some issues with sound, but this is an opportunity for you to ask any questions. While you're just thinking of your questions and typing them out for us, with your email I sent you some resources that can help you access both projects who have undertaken work using emotional touch points and patient and staff experience. And there is also a resource on the Creating Caring Cultures resources that gives you a very specific guide on how to undertake using emotional touch points and gathering those experiences. So we sent you out some guidance questions. Maybe we'll start thinking about them while you're typing. So apologies if we're looking up and down, it's just that we're trying to read the screen and ask questions at the same time.
So one of our first questions was whether people have had any experience of using narratives within their own work and practice. Jo, did you want to talk a bit about your experience while we wait to hear from others?
Yeah, so personally, many years ago, I took part in a leadership development program where I was encouraged to go and listen to a person's experience and I think it fundamentally changed the way that I thought about people I was caring for. I moved very much from seeing people as in a kind of 1D way, so people who had a disease or who I was trying to get better, to seeing a person with a history, to seeing a person who had a family and a life and hopes and dreams, and it really helped me move to see them as a person. And so I think that's the first thing, is to thinking about your own learning and your own development and how that helps you to be a better practitioner in the first place.
Absolutely.
So Sian, yes, we are recording this and we are going to attempt to put this on our website for you.
Yeah.
And for everybody that has had a bad experience of sound.
Similarly, my experience of so people often struggle in our educational settings to see beyond the sort of textbook descriptions of certain complex experiences. And in my world, in mental health nursing, that often relates to people who have been victims of trauma, so experiences of abuse. And one of the things that I think was probably the most powerful way that we could help people to understand the implications of trauma on the rest of that person's life was for somebody to share their lived experience, to share their narrative of that experience, and how that then influenced the way that they make relationships and how they see the world. And those students, when we did quite an in-depth evaluation of that process, because lots of people were saying, oh, that's too difficult, you shouldn't go near those types of topics, and what about the safety and all of that type of thing. And actually what they said was it had a profound impact upon them, that it had touched them on an emotional level, but that they valued that because previously they treated people who had those experiences in their past but had gone on to have difficulties in their adult life, probably with a diagnosis of personality disorder, for example, in quite a negative way. But now they understood why. They regarded people in the way that they did, and it would had a transformational effect on their attitudes towards particularly challenging client groups. So yeah, for me, I can really see that learning potential.
Yeah. And the other thing I wanted to share is, as a result of, so when I used to work in community hospitals, and I was chatting to older people about their life and their stories, one gentleman had noticed that we'd introduced some automatic external defibrillators.
Okay.
And through asking about his experience, he very clearly articulated that he didn't want me coming anywhere near him with that particular piece of machinery, and it led us very nicely onto a discussion about DNR and what he wanted in the end of life. And so that's an example of how I used listening to someone's experience to really improve care, because it led us very nicely onto quite a difficult topic through a very gentle way, and we could hear his wishes and hear what he wanted, and then we could document that all, and then we all as a team could really understand that. Yeah. Okay, so we're just going to open up your questions and try and see if we can see them all.
So Joanne asks, Sian says, I think we're lucky in paediatrics as we consider all the family and circumstances around the child. I think that's a really good point, how the models of care in different settings facilitate this way of working, and almost that it's taken for granted that it's so important to think about the child's context in order to be able to provide them with the family-centred orientated care. And isn't it interesting that the culture in that particular setting really lends itself to that? I'm not sure it's luck though. Sian, what do you think has facilitated that in your particular setting? I'd be interested to hear.
I think personally, I would say the culture of care around children is that you are allowed to be a little bit more creative. You're allowed to be a bit more different. Whereas when you're looking after adults, or you're not working in a permissive culture to try things differently, that it's very different.
So you think there's a permission there?
I think there's a permission there, and I think it's about the way we do things around here, which sets up a culture.
Absolutely.
Okay, so Joanne, have you any suggestions how we share the patient stories? Well, if you do audio recordings, then I would encourage you to share them at away days. You could set up special storytelling days. You could share them at meetings. You could share them anyway. Really, you could set up a podcast.
Yeah.
But it's really important that people hear them in the first person. At times I've run away days, and if we've had stories written down, then somebody will read them out so somebody else can hear them.
Yeah.
So that would be my suggestion.
Yeah. I've seen actually digital stories used really powerfully. They're short stories that are told to music and to images. And in a particular trust in Manchester, before every executive board meeting, they would show a story from somebody who was using their services. And what they described was that it really changed the heart of the discussion that they had. So whereas they would normally be reporting on the facts and the figures, that they started to think much more about context and meaning for the people that were using their services. So yeah, I think that can be really powerful, and interestingly, one story can have that profound impact, whereas when we're looking at the facts and figures, we need we need big numbers and we need a big sample and to show something that's representative. Actually, that representativeness goes to one side when it comes to stories, and it's really about valuing the messages that come from those individuals.
Absolutely. And I think it's not about throwing out the other data.
No.
So it's about valuing that data alongside the experience and the feelings data.
Yeah, absolutely. Sort of triangulating it all together,
absolutely.
isn't it?
Yeah. So Siobhan's saying she used an outcome that a child had expressed as what he wanted to support his long stay discharge from hospital, which was to feed his fish.
Brilliant.
Oh, nice. We used this sentence in the basis for his whole discharge plan. It changed everything, made it real, got each and every one of the MDT and family to strive to meet his to meet this most important outcome. Fantastic, Siobhan. That's a great example.
Really good example.
Great. Thank you. So that was what was important to that child.
Yeah.
And that then drove the improvement, which is great. Well done. So, do you want to read out Kelly's?
Yeah, so Kelly, I've carried out many after-death reflections to enable learning through reflection. However, I'm surprised how little things change. It might be that I could use a technique to enable these stories to come to life and make them more real for people. I would then feel it would be hard to ignore the changes and the learning that comes from these reflections because it makes it more real.
Yeah. Maybe if you go down to Kelly's comment below as well.
So recording people's reflections rather than minute taking. Yeah.
So absolutely, Kelly, if you record their people's emotions around that experience, as I did with Gemma here, you would gather a much more powerful, rather than assuming what needs to change. It's about giving people the time to hear, and then giving people the time to have some thought about what could they do differently. So that's but great that you're creating that space for that to happen. Maybe just think about how you could just be a little bit more creative about changing the way that you're using those.
And it's interesting, isn't it, how those stories can really motivate that change. So it almost provides an emotional impetus to want to do something different when you've heard about the effects it's had on that individual. When you were talking about the miscarriage stories, you were telling me about the change to that service as a result was huge, wasn't it?
Yeah, I mean, so women were saying how they'd just had this most traumatic miscarriage, but they were being cared for in essentially what felt like a store cupboard, and actually it was a store cupboard with a bed in it.
Yeah.
So there was no special provision or no recognition of how awful this was for this person. And there was a huge pledge from that workshop, the picture I show you, to go away and do something differently around that and recognise that this is really important to people. So
absolutely.
So Giselle said she's used narratives in the learning disability and patient setting to understand experience at the point of admission, using emotional touchpoint, using pictures, words, emotional faces. People created what was important for them using Lego, art and talking mats. Fantastic. I think it's fair to say that people that work in learning disability services are a little bit more creative in the way that they they do that, and I think there's a lot we can all learn
Absolutely.
from these things. So thank you for sharing that, Giselle. The themes of this informed the clinical governance group on how to improve patient experience on admission, but also what we needed to build on and enhance, such as peer buddy system. Really powerful. Helped to set agenda and priorities for the clinical pathway.
Fabulous.
Really good, really great example of how listening to people's stories really then improve care. Great.
And interestingly, to see the power of those stories on really influencing those agendas and priorities. So I think one of the things that sometimes people see this kind of data as is the kind of softer data, or the airy flary fluffy type of stuff, but actually it's so significant and powerful, as Giselle identified, and can feed into those very bureaucratic processes like governance structures and have a real influence there. So it's for me, it's I would say it's as powerful, if not more, than the measurable outcomes that often get prioritised.
Okay. Do you want to read out Sarah?
Yeah. So Sarah says she just used women's narratives to gain some feedback on the development of a specialist service. It's just in a couple, but that's been amazing. Really gone into depth and insight over the value and the meaning of care and aspects such as compassion. She's been challenged by some of the ethics around it, where they're stored, and now looking into trying to develop a shorter and quicker way to use routinely, so really integrating it into practice. And Sarah's in Newcastle and interested to take to the gynecology team, so she's wanting to link that up. So you can see the spread, the potential spread.
That's no problem, Sarah. I can email you and send you the project team report in Newcastle. But I'd also encourage you to link in with the Inspire Improvement Fellows, again, whose details are on the website, because a lot of them have tried some much quicker and shorter ways of getting feedback in terms of, mainly around their staff and patients. One way you might think of, Sarah, is taking your evoke cards with you and asking people to give you some feedback using the pictures or the words, and that would probably, how long did that take us? 5-10 minutes?
Yeah, absolutely.
You could really do that in quite a quick way. And record that or take pictures. Yeah, that's great.
And Sarah identified around the ethics, so things like where to store, and I think that's a really important point, Sarah. So when we're talking about where to share the stories and how they're used, we have to keep ethics really at the heart of those decisions. The key thing is about informed consent, as Jo mentioned in her presentation. So really making sure that the person knows exactly what the intention is for those stories, and that they are given written consent for them to be used in that way. Then there's sometimes that idea of anonymising to protect confidentiality. What I found in my experience, though, is that people often want their names and their identity attached to those stories. So again, asking that person to give their viewpoint around that is really important. But yeah, I would say definitely check out the regulations within your individual organisation, because they do vary depending on where you've gathered the stories.
Great. So great feedback, Kelly. Glad to hear you having some light bulb moments. I'm glad to hear this is helping. That's really helpful for us. Thank you. Sitting here looking at a screen is quite tricky.
Yeah, absolutely.
And Sian, you're thinking of using emotional touch points to help staff during a debrief support session. I think this would be great. I think it would lend itself particularly. What I'd encourage you to do is think about the touch points on that journey of the critical ill child. Think about those touch points, and then think about the space and creating a safe space for people to be able to share, because the safe space is really important.
It's absolutely integral, I think.
So think about ground rules, consent, those sort of things.
Yeah, absolutely.
Great. So Giselle's very nicely taken us to the next question.
Thank you,
Giselle. I'll pay you later. What barriers are there to gathering experience narratives in your area? And Giselle said challenges sometimes in other people seeing the value of this way of gathering evidence. And I would say absolutely. My point at the beginning of this presentation was that a lot of our cultures are embedded in valuing kind of evidence that proves or disproves something.
Measuring impact.
It's not really based in whether we're using that evidence to improve. So, but we can be advocates for that, and we can do that in small, gentle ways. We don't need to be doing a whole singing, dancing research project to make this happen. You can do it gently and quietly in your own practice in a safe way for yourself. And just showing people and letting them hear the stories will be the way that you help people move forward with this.
It's interesting. I'm a governor of a mental health trust, and I was observing their board a couple of weeks ago, and somebody reported back on the staff sickness rates due to work-related stress, which were fairly high for that organisation in a particular clinical setting. And it was interesting how the board instantly went to quite a critical place, and the chief nurse said, I've got to stop you here, let me tell you the story of what's happening in this particular area, and talked about some of the challenges. It's an acute mental health ward, so an admissions ward, and talked about some of the challenges and really put the context around this quite damning percentage that actually said, though these staff should be off at the moment with work-related stress, they need some time to recover from a traumatic experience. And so we should see this statistic in a completely different light. This is about our organisation taking care of the staff in that particular setting. And I thought, gosh, without those two sources of data, that would have been interpreted completely differently.
Absolutely. Yeah, that's a great example. Thank you. So Giselle's also saying emotional touch points are great with student nurses and understanding their experiences on placement. And
Absolutely.
That's kind of your bag, isn't it?
Yeah,
Working with student nurses. So.
Yeah, and I do lots of clinical supervision with student nurses as well, and we've made a definite shift in the way that we've approached that. So we move away as much as possible from kind of storytelling about some of the problems that people are experiencing, and being very much more focused on what are the emotions that they are dealing with and managing, and helping them to reflect and understand those emotions. But interestingly, the students don't always have the words for what those emotions are. So the evoke cards have been wonderful as a way of giving us that in to being able to access the emotional side of things.
Yeah, absolutely. Great. Sian's picking up on our point about creating a safe space and how tricky that can be. And you suggested using ground rules, and I would absolutely say that's really important, Sian. I think it's also about building relationships as people.
Yeah.
And valuing what people have to say, because the first time people share with you, they're watching to see what you do with it and how you use it. Absolutely. So I think that's really key. But any of you listening to this, you're welcome to pick up the phone, chat to me, send me some emails. I'm quite happy to help you with any of this.
How to facilitate that safety. Yeah,
absolutely.
I think you're right that is really cool. Yeah. We use it, rather than ground rules, we use the terminology a safe space agreement, and we ask people to think about a time where they felt safe to share their emotions in a group setting, and what was it about that particular environment that enabled them to do that, so that we can really kind of pinpoint what it is about certain group dynamics and the context and the facilitation that really helps people to feel safe.
So Siobhan's picked up the idea of confidence, and
absolutely.
this confidence to have to do something differently, and I would absolutely agree. It takes a lot of confidence, takes courage, but I think if you are vulnerable, if any of you've read or watched any of Brené Brown's TED Talks on vulnerability, having a go at this in a gentle, safe, and then seeing the power for yourself will then encourage you to keep doing this and to take it a step further each time. And that's Sian's put, what's the worst that can happen? So that's my key thing when I'm working with Inspire Improvement Fellows, and they say, I can't possibly do this, and I say, think about what's the worst that can happen, and then decide what you can do. So so thank you, Sian, you made me laugh.
I think you're completely right that sometimes people shy away from these types of conversations with their colleagues and their patients, and they say, oh, it's because they don't want to go there. But actually, often it's us that don't want to go there. We don't want to initiate the conversations that are focused around emotions, because we're worried once we've uncovered those emotions, there's a responsibility then to do something about it, to solve that problem. And my experience has been quite the opposite, actually, that people really feel the value of being listened to, as Jo said, and having that safe space to explore their experiences. And they often don't expect anything in response to that they really value that opportunity to be listened to. So I would say, just as Jo said, what's the worst could happen? Yeah.
And Joanne's just commented it can be quite surprising what you can actually find out by taking this different approach to hear about experience rather than, you know, how have we done today on a scale of 1 to 10. So this is all about, as we said at the beginning, thinking about understanding people's experience to improve care.
Absolutely.
Great.
So we've talked about ethics and we've talked about confidence. Is there anything else that people think of as barriers to this type of ways of working? Anything from your experience, Jo?
So I think sometimes barriers are confidence or not feeling that everybody will see it as a valid way of working, or people seeing you as a maverick or a bit of a strange person that comes out with the vote cards.
Fluffy things like this.
I do this all the time. I'm very used to being strange. But maybe reframe that and think about yourself as being creative, getting support to be creative, having headspace to be creative, connecting with a network of people. And this was my core idea when I suggested this idea of creating alumni. When I was in practice, I got all my creativity by connecting with people who were doing different things and had a passion for doing different things. So this idea of connecting and sharing and learning from each other, I think, is another great way of overcoming barriers. But start small and just give it a go. Okay. So while we've just got a few more questions coming in about that, I think the other thing that can stop us is the culture. This isn't the way we do things around here. So the thing I would encourage you to do is question that. Why don't we do this around here? Why is, I don't know, all of the evidence quantitative, for example? Why don't we value other ways of working? Why don't we value being creative? Why don't we value listening to all our stakeholders and what they have to say to us?
Absolutely. And I think it's interesting how so many people are commenting on that sort of the shared experience of being the one that is that questioning and critical person and willing to be the person that does something a little bit different. And my experience is that this stuff is infectious. So once you're the person that puts these messages out there that, you know, we're interested in your stories and particularly the emotional impact of your stories, then people want to get on your train and they want to follow your way of working. And I find that soon it becomes more of a cultural norm than the unique experience. So sometimes it takes that one individual to make that change.
And I think the other things, if we've worked in a organisation or a service or a department for a long period of time. So I used to work in an accident emergency department in Oxford, and we used to have what's called a goldfish bowl, which was like the command centre. And it had a big board, and we knew who was going where, but it was all glass, so we were totally visible. But we were rushing around, being busy, and it suddenly occurred to me I wanted to know what people's experience were. And nurses said to me, well, we can't possibly ask because, you know, they might tell us stuff we don't want to hear. And I should say, well, don't you think they can see what we're doing 24 hours a day? Wouldn't we want to know what impact that's having and therefore be able to have the ability to do something about that and make it better? So
fantastic.
Think about how many people are coming to your area already experiencing your culture of care, and wouldn't you want to know what that is so you could do something different?
Absolutely.
Okay.
We're coming towards the last few minutes now, Jo, aren't we?
So just quickly then, let's think about what resources are there for you, both internal and external, that can help you. Any suggestions?
Yeah, I mean, I would imagine this is going to be unique to all of the different organisations, and there will be resources and structures that will support you to gather this type of information. So one of the things I would say is if that is in existence currently, to tap into it within your organisation. Don't feel like you need to start this off from scratch. It may well be that there are processes in place to do that. and it might be the stories are being gathered but they're not being visible, they're not being used. So just check out what's going on already.
Yeah, I think the other thing is look to projects, because if somebody else has had a go at it, it might encourage you to have a go at it. So there are some examples in the library that I sent you as part of your resources. Maybe seek out people in your organisation who are mavericks as well, and connect with them. Connect with us as an organisation and see how we can help you. We're available on the end of the phone. That would be my suggestion.
Yeah, absolutely. And as I said before, there are resources that are stories that are already out there. The Patient Voices programme is one example that creates digital stories, and it might be a good tester to see how your organisation or your service or your team respond to a story that's relevant to your area of practice. So sort of introducing the idea with things that are already out there as resources might be a good starting point as well.
Yeah. So in the last few minutes, I just want to give you some feedback. So Chris has said, hello Chris and your managers listening to us.
Oh, hi there.
Hi, you're now going to set up a regular meeting to have some creative space to think about how we hear our patients' voices in a different way.
Brilliant.
And how we can share that with our teams. Excellent, great first step, Chris. Perhaps also think about challenging yourself to really hear your staff experience as well. In some simple ways, maybe not using the touch points, but you might think about maybe in your supervision groups or in other ways that we highlighted earlier on.
Absolutely.
Great. People are still typing.
And Giselle was saying about thinking about maybe starting small, and I think you're right about the power of the one-to-one interaction as well. Sometimes we think, again, when we think about the positivist research, it needs to be about numbers and representativeness and those kinds of things, but actually those one-to-one interactions may well provide the commitment and the motivation to want to change something, and utilising the stories to have a one-to-one maybe with a senior manager or the board, or those kind of things can be really, really powerful.
Great. Okay. So we'll just finalise our comments and say thank you so much for supporting us on our first event.
Yeah, absolutely.
It's been a bit of trial and error, and we've got some people saying thank you, they've got some ideas, we've got people saying they're having away days, we've got people with actions leaving, people have got some ideas for preparation. Thank you so much for joining us. This has been a little exciting and nerve-wracking all at the same time.
Yeah, so when we were saying before about have a go, what's the worst could happen, we're practicing what we preach.
Yeah, we are practicing it.
Yeah.
I will be writing out to you to get some feedback on how this has been, and for you to give us some ideas for something else that we could think about for the future.
Absolutely.
And I'm also looking to set up some face-to-face events, so if any of you would be willing to host those, then please do get in touch. And yeah, great. So one last thought, we are recording this.
Yes.
Obviously we'll need to test out what that sounds like, the quality of that, and we'll be looking to put this possibly on the FoNS website, but also connecting it to the University of Nottingham. And I just really want to thank Gemma. This wouldn't be possible without Gemma's support and your HELM team who have supported us with this platform.
Pleasure.
So thank you very much for that. And thank you all, and bye for now.
Thanks a lot, everyone.
Bye.
Bye-bye.